Hello, I'm Professor Maxime Dugados. I am the head of the Department of Rheumatology in Cochin Hospital, France, and I have the pleasure for introducing for you the manuscript summarizing a phase 3 clinical trial evaluating Baricitinib in rheumatoid arthritis. As you are aware of, rheumatoid arthritis is a chronic and debilitating disease. Unfortunately, so far, we have no curative treatment. That is, to give a treatment, disease is disappearing, to stop the treatment, and the disease is not occurring again. But at least we have drugs which are able to achieve what we call an acceptable status, that is either remission or low disease activity. The mainstay of therapy is currently to use what we call DMARDs. It's an acronym for conventional synthetic DMARDs, and in particular methotrexate. Using this drug, we are able to control 70 to 80% of the disease of the patient with an early onset disease. However, for a lot of patients, the disease still remains active and or the conventional synthetic DMARDs is not well tolerated. In this case, usually the current practice is to use biologics. There is emergence of new, what we call small molecules, and for the acronym of targeted synthetic DMARD, that is, they are synthetic, but they are targeted with a specific target. And that is the example of the JAK kinase inhibitors. And Baricitinib is a JAK kinase inhibitor inhibiting JAK1 and JAK2 in this pathway, which is very, very important in the field of inflammation. We run a phase 3 prospective randomized controlled trial evaluating Baricitinib at 2 doses, 2 and 4 milligram QD. And these two groups were compared to placebo in patients who have active rheumatoid arthritis despite the current use of methotrexate. In these patients, all of them were naive of biologics. That was just after the step of the conventional synthetic DMARDs. And the primary endpoint was the changes after 12 weeks of therapy, that is at week 12, concerning the percentage of patients who improved according to the American College of Rheumatology criteria, that is the ACR 20 response. This slide is summarizing what we have seen, and if you go directly to the primary endpoint, you see easily that at week 12, the percentage of patients achieving an ACR 20 response was higher in both the 2 and 4 milligram groups in comparison to placebo. But this slide is also showing two other elements when evaluating a treatment in rheumatoid arthritis. That is, first, the onset of action. And as you see on this slide, even after week 1, that is only after 1 week of treatment, there was a statistically significant difference in favor of the active treatment in comparison to placebo. The other component we can analyze on this curve is the sustainment, that is, whether or not there is a loss of response over time. And as you see in this slide, even through the 24 weeks of treatment, there was a sustaining improvement in both active arms in comparison to placebo. ACR 20 is the most discriminant outcome measure to evaluate a drug in comparison to placebo. However, nowadays, we want more in terms of improvement, and this slide shows the other percentage of patients achieving not only an ACR 20 response, but also an ACR 50 or ACR 70, and you see that the figures show every time a benefit in favor of the active drug, that is Baricitinib, either 2 or 4 milligram. But nowadays, we do not want not only to improve the current situation of the patient, we want to achieve a status of either clinical remission or low disease activity. In this trial, this was the case when looking at the patient with achieving a low disease activity state according to several composite indices such as SDI, CDI, DAS28, and I invite you to look at the manuscript and the supplementary material you will find in the website of the journal. You have noticed that there was a clear statistically and clinical difference in comparison to placebo with the two active arms, but from a symptomatic point of view, in this particular trial, it was impossible to differentiate 2 and 4 milligrams. However, and as an exploratory measure, in this trial, we have also evaluated not only the symptoms, but the structure by looking at the changes in the structural radiological parameter called now modified Sharp technique. And you see in this line that there was, despite it was only exploratory, there was a statistical significant difference in favor of the active compounds in comparison to placebo, but here there is a trend in favor of a more stringent treatment effect when using the highest dose, that is 4 milligram QD. JAK kinase inhibitors are true drugs, and we were expecting to see some adverse events. And you see in this slide the summary of what we have observed, and as usual with drugs targeting inflammatory pathways, we are afraid of the occurrence of infections. And here you see the summary of what we have observed, which was not so different than placebo, probably except for herpes zoster. In terms of laboratory abnormalities, we have observed, such as with other biologics, an increase in cholesterol level. Nothing really new has been observed in this particular trial. So, in conclusion, this trial, which is summarized in this manuscript, is clearly demonstrating that baricitinib might have his role in the management of patients with suffering from active rheumatoid arthritis and inadequate responder to methotrexate.